Hi, my name is Julie Hiller, and I'm going to do my IRB presentation on vitamin D deficiency and Roux-en-Y gastric bypass surgery. Vitamin D deficiency is now one of the most common medical conditions in the world. It affects 1 billion people, and it is due to lack of sun exposure, low dietary intake, and a diet deficient in vitamin D. It is a fat-soluble vitamin, and it's found in two forms. D2, which is ergocalciferol, and D3 cholecalciferol. D3 is found naturally in humans, and it promotes calcium absorption and it maintains adequate serum calcium and phosphate levels. It's necessary for bone growth and remodeling. Inadequate amounts lead to thin, brittle, or misshapen bones. Sufficient amounts prevent rickets in children and osteomalacia in adults. It plays a role in neuromuscular and immune function, reduces inflammation, and regulates cell proliferation, differentiation, and apoptosis. We get vitamin D through exposure to sunlight. The ultraviolet B portion is absorbed into the dermis and epidermis. It's absorbed by 7-dehydrocholesterol, which is derived from cholesterol. Pre-cholecalciferol is converted to D3 via thermal isomerization. And this production is dependent upon time of day, season, latitude, sunscreen use, and skin pigmentation. Very few foods contain vitamin D, but it can be found in fatty fish such as wild-caught salmon, swordfish, tuna, and sardines. Mushrooms contain it when exposed to UVB rays, and foods such as milk, cheese, yogurt, juice, cereals, and bread are often fortified with vitamin D. It can also be found in egg yolks. Vitamin D toxicity is very rare from dietary sources or sun, but has been seen more recently with increased use of supplements. It can cause weight loss, polyuria, nausea, vomiting, anorexia, and heart arrhythmias. And it can also cause permanent calcification in the soft tissues of the kidneys, heart, lungs, and blood vessels. This can lead to hypertension, headache, heart and kidney damage, hypercalcemia, and parathyroid suppression. There is an inverse relationship that exists between vitamin D levels and obesity. Often obese patients choose gastric bypass surgery, but unfortunately a vitamin D deficiency develops after getting this done. Obesity is a major health concern. BMI can be defined as greater than or equal to 30 kilograms divided by meters squared. It is known to have a 50 to 100% increase in premature death. 78 million people are obese, with 24 million being severely obese. And this prevalence has tripled between 1960 and 2010. Obesity is related to comorbidities such as dyslipidemia, hypertension, insulin resistance, cardiovascular disease. There are multiple risk factors for cancer, and it's related to chronic inflammation, oxidative stress, and altered gene expression. It is measured by serum 25 hydroxyvitamin. It is a favorite indicator because of its long half-life and fat solubility. Obesity is thought to occur because of changes in metabolism and lifestyle. Contributors to this obesity vitamin D deficiency relationship are reduced synthesis and increased degradation of vitamin D, decreased cutaneous synthetic capacity, reduced sun exposure, sequestration in body pools, and volumetric dilution. There's also an impaired synthesis related to liver function alteration and increased clearance from chronic inflammatory state. Vitamin D is also thought to be sequestered in adipose tissue. Let's talk about vitamin D metabolism. It does not require digestion. It is absorbed via fat and bile, and it's passively diffused through the cell membrane. 50% of it is absorbed in the jejunum and duodenum, although majority is through the jejunum. It's metabolized in the liver. It's converted to calcitrol by 1A hydroxylase enzyme. It's secreted from the liver and transported into the blood. The blood is the largest storage site of vitamin D, but it's also stored in adipose tissue. Bariatric surgery is the most effective treatment to achieve significant weight loss. It sustains weight loss and reduces mortality. Roux-en-Y gastric bypass is the most common weight loss surgery. It produces 70% excess weight loss and shows an average weight loss of 45 kilograms over a year. During this procedure, the stomach is divided into a large and small pouch. The small pouch holds about a cup of food. The small pouch is connected to the jejunum and it bypasses the duodenum, and this decreases the absorption of calories and nutrients. This surgery induces food restriction, which produces weight loss, but it also creates macro and micronutrient deficiencies. Some of the contributors of this are malabsorption due to anatomic rearrangement, reduced energy intake, reduced gastric volume, defective absorption, poor food tolerability, lack of vitamin D supplement compliance, and a reduction of 25-hydroxylation in the liver. To define vitamin D deficiency, the Institute of Medicine has a definition, and so does the U.S. Endocrine Society. The IOM defines deficient as less than 12 nanograms per milliliter, whereas the U.S. Endocrine Society says you're deficient when it's less than 20 nanograms per milliliter. This difference is due to differing goals and large gaps in the vitamin D literature. This prevalence exists prior to surgery. Studies show that 48 to 60% of patients had the deficiency before surgery, and levels are less than or equal to 20 mgs per ml. This previous deficiency plus the malabsorption occurring post-surgery makes it difficult to manage. The deficiency after surgery is seen in 50 to 80% of cases. 6 months after surgery, only 15% of women had appropriate levels. Studies do show an increase of serum levels at 1 month post-op, but osteomalacia is seen and defects in calciotropic hormones. How does this happen? Vitamin D deficiency persists when there's a decreased vitamin D-mediated intestinal calcium absorption, which leads to secondary hyperparathyroidism, which leads to a release of calcium that's stored in the bones. It is resorption of calcium by the kidney, and this presents as normal serum pH and calcium levels. How do we address this deficiency? Supplements are frequently prescribed, but supplementation varies among surgeons. Multivitamin formulations have not been shown to protect against these deficiencies, but D3 has been shown to be more effective when given at high doses than D2. There is no consensus on the optimal dose. What does the literature tell us? Studies report that ranges of 400 IUs daily to 50,000 IUs weekly have been given. The 400 IU daily dose did not correct the deficiency, where an 800 IU daily dose reduced the prevalence at a 1-year deficiency. 50,000 IU weekly versus 800 IU daily showed that the 50,000 produced higher serum levels. In another study, 800, 2,000, and 5,000 IUs were given. In the 2,000 and 5,000 IUs, serum levels increased significantly. And in one last study, where 50,000 IUs were given weekly versus 800 IU daily, the 50,000 had better outcomes, but the deficiency was not eliminated. What is the importance of determining the dose? If we don't determine the dose, the deficiency will persist. This will lead to osteomalacia and rickets and higher incidences of osteoporosis and hip fractures. It is no longer acceptable to continue with this trial and error mindset. The risks are too steep. Concrete evidence-based practice needs to exist. The goal and hypothesis of this study. The research goal is to determine what amount of supplemented vitamin D3 will achieve serum levels of greater than or equal to 30 mgs per ml. The research question is do Roux-en-Y gastric bypass postoperative surgery patients maintain serum D levels greater than or equal to 30 mgs when given 50,000 IUs weekly versus 5,000 IUs daily? The hypothesis is that high doses of vitamin D3 supplementation taken weekly will produce sufficient serum 25D levels. This is a quantitative design study. It will be done at Ohio State Wexner Medical Bariatric Center. It will be a longitudinal study taking place over 24 months. The exclusion criteria is included here. Just for lack of time, we'll scan over that. Demographics will be collected and informed consent will be obtained. Belmont principles will be addressed. Information will be de-identified, stored, and encrypted, and only the research team will have access to the master list. The groups will each take 5,000 daily or 50,000 IUs weekly. Both groups will take 2,000 milligrams of calcium daily. Serum D levels will be measured at 1, 6, 12, and 24 months. BMI will also be measured at this time. The date of the blood draw will record the season it is taken. The goal will be a serum of greater than or equal to 30 mgs per milliliter. There will be a questionnaire filled out at each blood draw. It will consist of the supplement and dietary intake of vitamin D fluids. There will be a 3-day dietary and supplement recall. Instructions will be given on estimating the portion size, and they'll recognize their previous week of vitamin D supplement intake. Weight, height, BMI, the procedure, blood will all have specific protocols which are listed here. A statistical analysis will be done using the G-Power software. A paired t-test will be done, and it will analyze the difference between time points of the serum D and BMI using mean and standard deviation. A 2-sample t-test will compare the mean values between low and high sun exposure months. And Pearson's correlation will show the relationship between concentration and secondary variables. The p-value will be set at 0.05. A sample size of 54 will be used, placing 27 in each group. The results will be presented in an aggregated summary. It's expected that 90% will have a deficiency at the time of surgery. There will be a temporary increase at 1 month post-op. It's expected that 92% of subjects will adhere to the supplement use, and this is an increase from previous studies which only show a 64% adherence. The group taking the 5,000 IUs daily at 12 months will have measurements of 26 ng per mLs, and the group taking 50,000 IUs per weekly will have a 12-month serum of 37.8 ng per ml. For BMI analysis, the 50,000 IU weekly group will have a decrease in BMI from 50.3 to 32.1 at 12 months, and the group receiving 5,000 IU will have a baseline BMI of 56.2 and a mean loss of 46.9 kilograms at 12 months. It is expected that at 6 months, 93% of the subjects will follow up. At 12 months, 54 will follow up. And at 24 months, it's expected that there'll be a high dropout rate. And the most common reason being for dropout is the distance from the testing site. Vitamin D can effectively increase serum D levels in Roux-en-Y gastric bypass patients. Previous studies show that 400 to 800 IU doses daily, 50% of the patients remained deficiency. In this study, greater than 71% of the patients had serum levels greater than 30 mgs per ml. It's reasonable to prescribe 50,000 IUs as their serum levels tripled in 3 months. This dose is safe. If compliant, the deficiency can be corrected. Toxicity is not a concern. Hypercalcemia is unlikely, but it is recommended that serum levels be checked every 6 to 12 months. Limitations of this study include noncompliance with oral intake of vitamin D, incomplete follow-up by some patients, and failure to recall dietary and supplement intake. I thank you for your time.